liver function tests can actually be very difficult to interpret. What I want to do is show you how I lay out my liver function tests in annotation form on a piece of paper and explain why I do that. I'll give you the basest form of clinical reasoning, that is, when you see an abnormality on the LFTs, what do you reflex? You should not reflex order these tests in every patient, but as you learn and begin to develop your skill in clinical reasoning, you'll see which ones you need at which times and which ones you don't. So we'll start off with the basest form of clinical reasoning, the reflexive tests based on the LFTs, and then we'll get into the more complicated task of actually interpreting liver function patterns and then some of the details that are contained within each 4 patterns. So let's start off just with the LFTs. I draw my LFTs a little different than most people in the country. This is the way I was taught to do it in my residency, and it makes a lot of sense. At the top is the total protein and the albumin. At the bottom is going to be the AST and the ALT. And I'm going to color code these for you. The total bilirubin can either be red or green, and you'll see what that means in a little bit. The D-bili goes next to the T-bili, and it's in green because it is associated with the alk-phos. Now, let's explore what the different meanings of each of these laboratory values and how you can be distracted by something that's not in the liver. These are going to be the reflex tests you order in order to begin to interpret LFTs. First of all, the total protein minus the albumin is going to be the protein gap. And if you have a protein gap, that is the total protein minus the albumin, greater than 4, it means that there is something else other than the typical proteins making up the total protein. That usually comes in the form of immunoglobulins. So you are going to go looking for things that produce immunoglobulins. The simplest form of this is just your own body's innate natural immunoglobulins doing what they're supposed to do. So a differential diagnosis for an elevated protein gap might simply be sepsis. But it can also be the things that people start to think of when they see an elevated protein gap. That is the chronic viral infections or cancers that are going to make extra proteins be floating around. That is HIV, Hep C, and multiple myeloma. So if you see an elevated protein gap, and the clinical scenario doesn't say there's some sort of inflammatory state, sepsis or autoimmune, we'll put autoimmune on here as well, that's when you go screening people for HIV and Hep C. People don't like this, attendings don't like this, because if you see an elevated protein gap in a 32-year-old, you're going to go looking for multiple myeloma because you don't know that multiple myeloma only occurs in people who are around 70. Can that 32-year-old have multiple myeloma? Sure. But a person who is 33 with an elevated protein gap probably has something else and doesn't not need the SPEP or the UPEP for multiple myeloma. But if you were just going to do reflex testing, what you would do is get HIV antibodies, that is an ELISA or the OraQuick. You'd get a chronic hepatitis panel, which would include Hep C antibodies, and multiple myeloma, SPEP, and UPEP. I'm going to say this again. You should not reflexively get these tests unless you do not have an alternative explanation for the elevated protein gap. That's a protein gap differential. Let's talk about albumin. There is no conditions in which albumin is increased. So there are no conditions where you have to be like, why is the albumin 6? You won't see it. A normal albumin is 4. Decreased albumin are caused by the oci. That is cirrhosis, nephrosis, and gastrosis. This is a mnemonic to tell you of the diseases of albumin. Cirrhosis, you cannot build the proteins. Nephrosis, you spill the albumin in your urine. And gastrosis is either going to be a protein-losing enteropathy or simple malnutrition like kwashiorkor. The testing for those is a bit more complex, so we're not going to go into them. But when you see a low albumin, think of these three conditions, the three conditions which would decrease your albumin. Now you may have noticed that these are color-coded, right? And the total protein, albumin, AST, and ALT are all black. They're all black because they are liver enzymes. When your liver is broken, the albumin will go down. When your liver is inflamed, the AST and ALT will go up. The AST may also be muscle breakdown. So consider if you see an isolated elevation of the AST, or the AST is much higher than the ALT, it might be indicative of liver injury, and certain patterns do follow that. But if you see an elevation of the AST, think about muscle breakdown and check a CK or a CPK level, depending on what your laboratory is, looking for muscle breakdown and potential rhabdomyolysis. Certain patterns, such as an AST to ALT of 2 to 1, may be indicative of alcoholic hepatitis or cirrhosis. They don't have to be 2 to 1, and in general, the higher the ratio, the more likely it is to be alcohol cirrhosis. But in both of these conditions, recognize that the AST and ALT don't get very high. You won't see enzymes in the thousands. Very few things do that. So if you do see AST and ALT in the thousands, think of this very short list. Budd-Chiari, autoimmune hepatitis, an acute viral infection, that is Hep A or B. If it's not those, CMV and EBV can do it. Shock liver, that is the person is floridly hypotensive for something else. And Tylenol, that is acetaminophen toxicity. These are the things that are going to get your AST and ALT to the thousands. And I want you to recognize that Budd-Chiari means any sort of clot in the portal system, either the portal vein, the hepatic vein, doesn't matter. Something that compromises blood flow into or out of the liver. So if you see AST and ALT in the thousands, think of these disorders. If you see AST, ALT 2 to 1, think of alcoholic cirrhosis. If you see an isolated AST elevation, make sure it's not muscle by ordering a CPK level. In green are going to be the things that involve the biliary tree. There's not much else that causes an elevation in the direct bilirubin, that is the conjugated bilirubin, other than biliary tree pathology. Alk phos, however, can come from bone, and you assess whether or not it's coming from bone by getting a GGT. The GGT is specific for biliary tree, so if you have an elevated alk phos and not elevated GGT, that's bone. If you have an elevated alk phos and an elevated GGT, that's biliary tree. Finally, T-bili can come either in the form of conjugated or unconjugated. And you order the D-bili to differentiate. Because if you just order liver function tests or a Chem 20, that is a CMP, you are not going to get the D-bili. The D-bili has to be ordered separately. So most of the time, this tree is just like this, only there's a blank spot for D-bili. If you see an elevated bilirubin, you must then get the D-bili. So I'm going to switch over and start talking about the different patterns. And that's why I've color-coded. I want to show you a picture of the liver system as I see it. This is the bloodstream that feeds the liver itself, and the biliary tree. The colors should make a lot more sense now. If the liver is inflamed and has damage done to it acutely, knowing the color codes, you will suspect then that the AST and the ALT are indications of hepatocellular injury. The albumin doesn't drop until it becomes chronic and you're cirrhotic. If there is damage to the biliary tree, either the gallbladder or any of the biliary system, it is not a surprise that you would expect to see elevations in D-bili and alk phos. And notice that the only one in red is the T-bili, because there are other conditions that can cause elevations in the bilirubin. That's jaundice. So I want you to see that hepatocellular injury is primarily AST-ALT. Biliary injury is primarily D-bili and alk phos. And don't forget about other causes of jaundice. Let's run through them now, starting with number 4, the one that people miss all the time, an infiltrative pattern. I put it number 4 because you're going to see it the least. And we're talking about it first because it's the one people miss. In an infiltrative pattern, you have primarily an elevation in the alk phos and alk phos alone. There may be a component of the direct bili, and there may be AST and ALT. But if you see an alk phos that is much more elevated than the D-bili is, that is, you're thinking, well, you know, I know that an elevation of alk phos and D-bili together mean obstructive pattern, but the alk phos is much higher and the GGT is also high because it is biliary. Think infiltrative. What you're going to see on the liver function tests are going to be an elevation of the alk phos and D-bili. So you're probably going to get an ultrasound to assess whether or not there is obstruction. You are going to see no obstruction on any test that you do. And you're going to be confused because you know that elevations in alk phos and D-bili mean elevations of obstruction. That is the biliary pathology, but there's no obstruction identified. That moment will be the time you remember me saying that infiltrative disease is an alk phos out of proportion to the D-bili without evidence of obstruction. And in order to find out what's going on, you jump to biopsy. Because the diseases of infiltration are the same ones of the heart. That is going to be things like sarcoid, amyloid, hemochromatosis, infiltrative cancers, and generalized fibrosis. So this is the one you're going to see the least. And if you remember the lecture, you're going to see the pattern. People will jump on board for obstruction. They won't find it, and you'll be the one to recommend the biopsy. Let's work our way back up. This is an infiltrative pattern. The next is going to be jaundice in general. And here we need another picture just like the one we drew. In jaundice, there are 3 possibilities for the cause of the jaundice. And that is going to be pre-hepatic, post-hepatic, and intrahepatic. And we have a jaundice lecture in the regular series on GI that you can go and review. But briefly, the steps on which bilirubin is processed. Bilirubin makes jaundice. You are going to have hemolysis of red blood cells. That hemolysis releases hemoglobin and is carried to the liver in the form of unconjugated bili. Unconjugated bilirubin then gets into the liver in one first step, gets conjugated within the liver, and then gets excreted into the biliary tree. In unconjugated bilirubin becomes conjugated as the rate-limiting step within the liver. And then that conjugated bilirubin is sent and excreted in the stool. Follow along with this now as we go through this process. If you have pre-hepatic jaundice, it is going to be a product either of hemorrhage or hemolysis. Hemolysis increases in the blood. Unconjugated bilirubin increases in the blood. Delivery to the liver increases, And so the conjugated bilirubin is also going to go up, and so will the bilirubin in the stool. But because the rate-limiting step is conjugation of bilirubin, as more and more unconjugated bilirubin ends up at the liver, not as much can be conjugated. So pre-hepatic jaundice is going to be primarily unconjugated bilirubin. So if you see a very elevated T-bili and a only slightly elevated D-bili, you are almost guaranteed to be hemolysis or hemorrhage. So an elevation, an isolated elevation in the T-bili is indication of hemolysis. If you flip to the other side of the liver, that is, there is an obstruction that prevents bilirubin getting to the stool, the amount of hemolysis is the same. The amount of unconjugated bilirubin is the same. You are not overwhelming the rate-limiting step, so the amount of conjugated bilirubin is the same. But you can't get that conjugated bilirubin into the stool. So as more and more conjugated bilirubin builds up, picture this like a pail of water as you turn the faucet on, there's no drain, it's just a bucket. And eventually the conjugated bilirubin fills the biliary tree and spills back into the bloodstream. And that's not actually what happens, but that's a way to remember it. The overflowing of the bucket full of water is the same thing as conjugated bilirubin building up and eventually spilling back into the blood. So an elevation of primarily conjugated bili, that is the T-bili is up and the D-bili is up, is an indication of obstruction. Now whether that obstruction is from a gallstone or from a stricture, it doesn't matter. If you see lots of T-bili and lots of D-bili, that's obstruction. Intrahepatic jaundice is very complicated because, as we can see, there's a step that uptakes the unconjugated bilirubin, the conjugation step, and the excretion part. If you have a dysfunction of the first step, such as Crigler-Najjar and Gilbert's, which are syndromes of uptake of bilirubin, you're going to have primarily unconjugated hyperbilirubinemia because you can't get that bilirubin to the conjugation step. Conversely, if you have Dubin-Johnson's or Roeder syndrome, which is a problem with excretion, you'll have primarily an elevation in the conjugated bilirubin because the conjugation step is accessible. If you have chronic liver disease, such as cirrhosis, or you suffer an acute hepatitis and the liver gets messed up, you can't tell which direction it will go, primarily unconjugated or conjugated. So feel this. If you have an overwhelmingly large total bilirubin with no conjugation, that's prehepatic. Think hemolysis and hemorrhage. If you have an overwhelmingly elevated total bilirubin and a lot of it, like 50–70%, is conjugated, that's obstruction. If it's somewhere in that middle zone, being like, well, it's not really elevated that much, I can't really tell, that's probably intrahepatic. You are not going to be able to tell from the number alone exactly the diagnosis, but it can help you funnel into what you're going to look for. The blood smear for the hemolysis, the ultrasound for the obstruction, or finding out what disease is afflicting the liver. Again, we have a whole lecture on this. It's 20 minutes long. It's in the medicine section under GI. So I want you to just see this as an overview and feel that the T-bili and the D-bili can direct you to one of the three. Let's move on now to an easier thing to understand, which is the second obstructive pattern. In an obstruction, what you're going to see is primarily an elevation in the alk-phos and the D-bili. There is going to be inflammation of the biliary tree, releasing alk-phos, and because there's an obstruction, as we just talked about in jaundice, elevation in the direct bilirubin. But the inflammation or the obstruction may impact the liver. Because there's decreased flow out, it may cause some inflammation. So you might see elevations in the AST and the ALT as well. But primarily you're going to see the dysfunction in the alk-phos and the bilirubin. We have two separate lectures in the medicine and surgery lectures, one on gallstones and one on obstructive jaundice. I'm going to highlight each of those lectures right now to show you the difference. if you have a liver and you have an acute obstruction, say from a gallstone. This is an example of choledocholithiasis because the gallstone is in the biliary tree, not in the gallbladder. It gets obstructed, bile can't flow. What happens is the liver is going to become acutely inflamed, and the gallbladder is going to become acutely inflamed. What you'll see is inflammation, the thickened gallbladder wall, the pericholestistic fluid. And because the gallbladder system hasn't had time to adapt, only mild dilation. Inflammation hurts. So a painful jaundice is going to be acute and is more likely to be gallstones than cancer. You're going to see the elevation of the AST and ALT. You'll see an elevation in the amylase as a product of the gallbladder disease, and the ultrasound will show you not that much dilation, but a very thickened, inflamed gallbladder. On the other hand, if you have a slowly developing tumor, that slowly eats its way in, as it does so, the biliary tree is not acutely impacted, and so it has a chance to dilate. So what you'll see is a thin-walled, big, distended gallbladder, and you might even see big dilations of the biliary tree, but no pain because the body has had time to adapt. There's no inflammation. So painless jaundice is indicative of a slowly developing obstruction, and that is either going to be cancer or a stricture. Your clinical presentation and the history will tell you which it is. The cancers that are most oftenly involved are the cancers of the head of the pancreas, ampulla vata or cholangiocarcinoma. Strictures can occur in primary sclerosing cholangitis and in anyone who's had a previous ERCP. The ultrasound will help you differentiate the thickened gallbladder wall from the thin, huge, distended gallbladder. So when you see elevations in alk phos and D. bili, your next step is to try to decide, is it painful and acute inflammation, or is it painless and a chronic developing process? Both are going to be assessed in the same way. Both are going to be managed in the same way, except in the case where that acute inflammation needs to be relieved immediately with emergent ERCP. Finally, the last of the liver patterns, and the first because you're going to see it the most, is hepatocellular injury. This should not be surprising. You're going to see primarily an elevation of the AST and the ALT, and because inflammation can happen further down and there are biliary tree structures within the liver, you might see elevation in the alk phos or the D. bili. There's not much more to say about hepatocellular injury. We've already talked about the things that get you into the thousands. We know that AST and ALT elevations are going to generally rise together, and not very many things get it over 1,000. If you see an AST to ALT ratio greater than 2, think cirrhosis and alcohol. But now I want you to be able to recognize that when you look at liver function tests, what you should be doing is attempt to categorize each pattern into one of these four. Either hepatocellular with a lot of AST and ALT elevations, maybe in isolation, but plus minus the alk phos and D. bili. Obstruction with primarily elevations in the alk phos and the D. bili, plus minus some AST, ALT. Jaundice, which is going to be isolated elevation of bilirubin, and it's up to you to determine if it's pre, intra, or post-hepatic. And finally, infiltrative patterns were primarily alk phos without D. bili, without AST and ALT. And this is going to be the tricky one, and if you identify this, you'll save a lot of unnecessary tests by getting the biopsy. And if we come back to the very beginning, if this was overwhelming and you can't really yet identify these patterns, simply stick with the possible differential diagnosis from this tree and just get the reflexive test. What this does is, at the 2 o'clock admission, when you don't have someone to call, you know what test to get so that you can assess it together the next morning with the attending and the rest of the team. And that is liver function tests. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.